Good morning. Welcome to the Grand Rounds. Today we have Dr. Ashwin from the Department of Medical Oncology to present the Grand Rounds on metastasis, not the end of the road. Actually, if you see the recent insights such as the recognition that disseminated cancer cells can lie dormant for years before seeding secondary tumors have suggested novel strategies for fighting metastatic cancer. And when it comes to head and neck cancer, we talk about, if the disease is localized to that area, the survival, 5-year survival is 80%. If the disease goes to the neck nodes, lymph nodes in the neck, it becomes from 80 to 40%. And if the patient has a distant metastasis, that is in lungs, bone, or liver, the survival, 5-year survival goes down to 20%. That's what it says about the metastasis. Now, let's say Ashwin has something new to tell us, that it's not the end of the road. There are many options available, recent advances and things like that. And whatever he is doing here in CMC, we are looking forward to listen from Ashwin. Ashwin, please, the platform is yours.
Good morning to everybody, and thank you, Ashish sir, for giving a kind introduction. So a lot of people ask me, is the slides visible?
Slide is not started. Yes, you can make full screen. Yes.
A lot of ask me why this topic, why do you choose this topic? Well, as a medical oncologist practicing in India, majority of the patients that you see who come to you would be in advanced stage, at least locally advanced, if not metastatic. And especially in a city like Ludhiana, which is a second-tier city, majority of the patients will come to you after first-line therapy for an opinion. And in India, generally, people come late for treatment. But what is interesting in oncology is that 2010 onwards, there have been a lot of changes in the way a lot of medicines have come in, a lot of molecular things have come out, and the way we manage patients have dramatically changed. It's my own experience. I started oncology training in 2013 with Dr. Kunal, and a lot has changed from that time to the time I became a DM resident, and from the time I passed out to the time I'm practicing. The way that I look at these patients has changed, the survival has changed. So today's talk is going to be a talk on the recent advances and how we put it into practice in CMC Ludhiana, and to show that we were not behind the world, and in a way, but as simple as possible, not going to be very on-code type of discussions that everybody can get a hang of it. So with that, I would go on to this talk, and in a way, this is my experiments with truth. When you pass your DM and you come out, you want to try out whatever we've been taught. You're eager, you're anxious, and my child always tells us that I want to go to become a scientist and make magic potions when I grow up. So this talk is her father's experiments with truth. So the outline of the talk would have a little bit of stats, 3 years of a metastatic journey, and at the end of the talk, I would give a glimpse of the overall survival or the long-term survival plan for the Department of Medical Oncology. So let's begin the Arabian Nights, a story a day to survive. That's how I took my survival here. Each day I saw one patient. I survived a day, a week became a month, a month became years, and 3 years. I just can't believe 3 years are done and dusted. So let's start the Arabian Nights. Every case I discuss will be a story, and let me assure you, there's no exaggeration of events. What I'm discussing happened in the OPD, and I'm sharing my experiences without an exaggeration. So we'll discuss each sector, a few cases each. So breast cancer, and all of us know a bit of a stats. We know that the incidence of breast cancer in India is now almost the same as the world. It's the main killer in women. Indian patients tend to have more of a triple negative subtype. Our patients are more younger than the West. People come to us more advanced disease. But in spite of all those, the Indian scenario is also changing. So let's discuss the first case. This is a 50-year-old postmenopausal dancer. She was a professional dance teacher. She had a very strong family history of CA breast. Her mother and aunt both had CA breast. So 2017, she had come before I had come here, and she had a very small breast lump, and the biopsy was done. Sometimes I always wonder how she managed to pick up this breast lump in the first place. And as all of you know, when you treat breast cancer today or any cancer, it is not just one type. It is a heterogeneous disease. The time is gone that we are going to treat everybody the same way. So when you look at breast cancer, we look at the hormone receptors, and then we decide and prognosticate the treatment, and the treatment is planned based on the receptors. So her ER/PR hormones were positive. Her HER2 hormone, which we looked, was equivocal at that point of time. Staging was done, showed mediastinal lymph nodes, axillary lymph nodes. She was very well managed. Really appreciate Radiation Oncology for pushing the family to go ahead and get an mediastinal lymph node biopsy, because that would have changed the way we treat this patient. A biopsy was done for mediastinal lymph node, confirmed that it was metastatic. So it was palliative from the beginning. Very small primary mediastinal lymph nodes, palliative setup. Initially the FISH report was not available. So she was started on systemic chemotherapy, weekly paclitaxel. She completed 12 cycles, and then she was put on tamoxifen, and she was doing well. She was referred to me when she had disease progression, and when she had disease progression, she had lymph nodes or bony mets, and that's when she comes to me. So what is important here is that up to 2015, when you had a hormone-positive breast cancer, the maximum that you could do was fulvestrant followed letrozole, fulvestrant. There was some data on everolimus and Bolero. Bolero study was there, but automatically most of the patients would get chemotherapy sooner than later. The median PFS was around a year with this AIs, and a new set of drugs came into practice. The first of these drugs was palbociclib, approved in 2015, 2017, ribociclib, 2018, abemaciclib. One after the other, drugs came into the picture with US FDA approval. What are these drugs? So they are CDK4 and 6 inhibitors. And what exactly do they do? So all of us know the cell cycle. We know that all the cells go to the cell cycle. There is a G0, G1, S, G2, and an M phase. And in the cell cycle, there are checkpoints in the body has created that if there's any abnormality at any point in the cell cycle, these checkpoints can block the cell from going ahead. Now, it was shown in preclinical studies that patients who had a hormone receptor positive breast cancer, the ER stimulated the cyclin kinase Ds to be activated. And this led to the activation of cyclin K and 4 and 6. And what they did is the retinoblastoma protein was inactivated by phosphorylation. So what happens when you inactivate the retinoblastoma protein is the fact that the cell cycle, the checkpoint is taken off and the cell cycle continues and proliferates. So this was seen in hormone-positive breast cancer. And because we understood this, they said, let us develop a drug that prevents the cyclin D from activation. And they developed the CDK4/6 inhibitors. Now, at that point of time, based on the Paloma studies, this is a third-line setting. We used a combination of letrozole and palbociclib. She did very well. And then after around 9 to 10 months, she had disease progression. So this point of time, this happens in clinical practice. When you have a disease progression, the patient's upset. All the more reason because at this point of time, the patient assistance program which a company gives you after 10 months of lifetime free comes off. The patient feels upset because they're paid initially. And at the time when the medicine is supposed to be free of cost, there's disease progression. So I spoke to the husband and I said, see, you are on a third line, so it is expected to last only this time. We need to switch therapy. But he also had done his homework. He had met people around, and he was also in the medical field. So he said, why can't we keep the palbociclib as a backbone and switch the hormonal therapy? Now, not heavily evidence-based in this era, but the main thing is, what is important is that when you treat HER2-positive breast cancer, there is evidence of keeping the trastuzumab backbone and switching the chemotherapy. When you treat lymphomas, you have the evidence of keeping rituximab as a backbone and changing the chemotherapy. So there wasn't heavy data, but in the circumstances we discussed. I also, at that point of time, in 2019, the data was coming about a mutation and a drug to block the mutation for this. For my safety, I documented in the file, but I wasn't very pushy. I didn't push for that test. So what happened is that we agreed to go ahead, and throughout the time I made the decision, I kept thinking in my heart, did I miss it? Should I have a push for the PIK3CA mutation? So what does this PIK3 mutation is actually? This is a mutation which you see in around 40% of the patients who have a hormone-positive metastatic breast cancer. At this point of time in 2019, the data was just coming out and a drug was developed against this mutation, alpelisib, which showed a progression-free survival for patients who do very bad on hormonal therapy. In my heart of hearts, I kept thinking that maybe I should have pushed around, but then, the practice is very difficult from the patient sitting across to you. But luckily for me, there was a twist that is totally unexpected. One of the blockbusters I watched and I really appreciate was a movie called Drishyam. I know there's been remade in all the languages in India. Terrific movie. What happened in my patient is I'm sitting in OPD in the evening around 4:30. The family rushes in the patient on a wheelchair. She is just in pain, and we couldn't examine her. To be very frank, I just couldn't examine her. She was shouting in pain. She kept saying abdomen pain, abdomen pain. I couldn't make her lie down, and she was just sitting up all the time, like a gallstone sort of a pain. So gave her morphine, shifted to the ultrasound. Ultrasound at that point of time, I was in the ultrasound room that time, showed a minimal effusion, some gallstones, nothing much. So around 7 o'clock, we settled her, gave put on morphine infusion. I go back home. So I was thinking that metastatic disease, gallstone, surgery, let's see how to take it forward. 9 a.m. I go for rounds, and she's kind of okay, but she's sweating. I mean, pain is not there because of infusion, but she has some discomfort in the right shoulder. Examination, there's an absent red sound. At this point of time, we do an X-ray. There's a massive effusion, and I'm not exaggerating. 12 hours before, I was there in the ultrasound room. Ultrasound didn't show anything on effusion as big as it. This like, entire lung was wiped out. I knew we were heading for a mess at this point of time. We urgently asked for a CT scan, and I did a pleural tap at this point of time. The pleural tap, I'd inform pathology that I'm sending a tap, get me the results. So they immediately informed me by night. I think 6 o'clock, they informed me that it is malignant. I didn't wait for these IHC reports to come, and I used a doublet chemotherapy because she was in vessel crisis. The CT scan had multiple liver mets at this point of time. Now, here's a first bomb that happened. Use chemotherapy, 3 to 4 days, she starts improving. In a week, I discharge her, she goes home. The IHC, which you do on the cell block, our pathology team is able to do cell blocks and IHC, for which I'm always very thankful. So IHC showed something that is a huge learning in my career. I mean, the histology of the cancer had changed from a hormone receptor positive to a hormone receptor negative. And that is exactly why she behaved in a very aggressive way. I mean, she had a vessel crisis when she had come this time. This is known to happen in around 10 to 15% of your patients with CA breast, around 5% of your patients with lung. As you treat these patients, mutations, the cancer cells then mutate and change the histology or change their, bring in new mutations. And this is a huge turning point. At the point of time, this changed the way we treat. So we used 6 cycles of chemotherapy on her. She did extremely well. At this point of time, I also remembered that now she's triple negative. She has a very strong family history, and she's young. There is a possibility that she has a germline mutation. So I've asked for the germline. It is again difficult to convince the husband, but I used a coupon to bribe him to use the testing, and we got a germline mutation test done alongside it. So after 6 cycles of chemotherapy, she's back to performance status 1. CT scan shows 70% reduction in the size of lesions. Patient is much better. What do you do now? So you have 3-4 options. One, you continue the adriamycin, but adriamycin can lead to cardiac toxicity that is irreversible. So that is something I will never do after 6 cycles. You can keep on, she's achieved good palliation. So she has achieved good palliation. She's asymptomatic now. You can keep her on follow-up every month, keep seeing her tumor markers symptomatically, and then bring in the next agent. Or you can start another agent like capecitabine. In lung cancer, maintenance therapy is approved. In colon cancer, maintenance therapy is kind of considered okay. Breast cancer, in this subset, not heavy data. I mean, so I spoke to the family. The husband said, see, we know it's an aggressive disease. We want some sort of treatment to prolong it. So please go ahead and use a maintenance therapy. So because she was triple negative, I used capecitabine at this point of time. Now, I have a peer group. I have people whom I discussed. So there were mixed opinions from a lot of people. But anyway, I said, that's it. Let's use this drug. And then I never knew that after Drishyam 1, Drishyam 2 was just behind the screen. 10 days after taking capecitabine, they come to the OPD, headache, vomiting. Now, and then the husband, the first thing tells me is that it is after we start this medicine, doctor, that we have this problem. And suddenly, as a oncologist, you're panicking. You're thinking that, oh, I should have used logic and not use a drug. So again, I was upset, but then they were calm enough, admitted her. We do 2 serial MRIs. The first MRI we did was normal. CSF showed slightly elevated proteins, no malignant cells, all the TB workup negative. Fundus had papilledema. I got neurology to see the patient. So they said we could treat it like an intracranial hypertension, benign intracranial hypertension. We put an acetazolamide. She improved. Discharge after 5 days. Goes home again after 5 days, comes back, severe headache, vomiting. The story starts again. Second MRI, venogram, everything again shows the same thing. The CSF shows the same story. We increase the dose of the acetazolamide, do a therapeutic tap. She feels better. This time I'm panicking because husband again said, doctor, the capecitabine. So capecitabine can cause toxicities, but they're usually gastrointestinal, especially if you have a DPD mutation. So the profuse diarrhea, you can have mucositis. But in oncology, everything doesn't work 1+1. So I was also afraid maybe we were having something in the brain with a drug. We did a DPD mutation that is negative. The third time she came, luckily for me, the MRI showed leptomeningeal enhancement, and the CSF this time was positive. Throughout this case, when this patient kept coming back, I was discussing with my mentor, Dr. Seva, and I said, sir, I'm panicking really in this patient. So he said, 90% Ashwin, this is malignant only. You still have to keep doing CSF. So a huge thing that I learned with this patient is that you still have to keep your options open and don't rule out it is not metastatic. You have to keep the other options open as well, get cross multiple consultations, and keep your eyes and ears wide open. So by this time, her BRCA report had come and she was BRCA1 positive. So you had a patient with a strong family history, BRCA is positive. I started on intrathecal methotrexate to clear out the CSF. That happened. When you have brain enhancement, survival rapidly comes down. So again, what do? Do we call it quits? Come on, I can't allow it at this point of time. So we decided to do a literature review. And at that point of time, these drugs were coming into India, PARP inhibitors. What are PARP inhibitors? They are ADP ribose polymerase inhibitors. In India right now, you have olaparib and rucaparib approved. So these drugs are coming into oncology big way, especially in ovarian cancer. The data is extremely good. Right now, we have 3 to 4 patients on PARP inhibitors already. So what does this PARP inhibitors do? So it's important to understand. So I said all the things that have happened in the last 10 years, I've understood because we have understood the mechanisms behind the human body and the basic repairs. So all of us know that we have mechanisms to, our DNA is in constant damage, and the body has inbuilt mechanisms to repair the damaged DNA. If you have a single stranded DNA break, a PARP enzymes repair it by base excision repair, and the cell becomes normal. If you have a double-stranded DNA damage, the homologous recombination mechanism repairs the double-stranded break, and the cell goes back into the normal cycle. So this is a known fact. Now, using that principle, and when you have a germline mutation, and when you have the fact that the patient has a deficiency in the homologous recombination mechanism, that is already known because patient has a germline defect. You add insult to injury by bringing in a PARP inhibitor. So the PARP inhibitor prevents the single-stranded breaks from repairing. That leads to more double-stranded breaks. More the double-stranded breaks in a patient who doesn't have enough capacity to repair it leads to cell death. So you're trying to beat the cancer at its own game. So evidence, everything in oncology is evidence-based. And there was an Olympiad study which looked at patients who had relapsed refractory CA breast and had BRCA mutation positive and had been given this drug and showed a 42% reduction in the risk of progression. Based on this, I wanted to use a drug. Drug is extremely expensive. So what do? You tie up with China. You sign a deal with China. I am close friends with Dr. Chandan Das in PGI. He's a contemporary of mine. So I spoke to him. I knew that he was doing a trial on olaparib. He had a clinical trial with him. So I spoke to him and I said, see, I have a patient. See if she fits into the trial and help the patient. The patient was sent over to PGI. She fitted into the trial criteria. She took the medicine and she walked back to life. And for a patient who was bedridden, tremendous AIDS, she did very well. But like in all these patients in cancer as of now, she developed progression in the brain. On top of that, she developed COVID, developed acute kidney injury. She came out of all of that, but then she was sick after that. So we put her on supportive care. They went back home and she passed away peacefully at home. So what I learned in this at this point of time was that it's going to be a continuum care. CDK4/6 inhibitors are the standard of care in metastatic breast cancer. If possible, if affording, these agents should be used upfront to get the maximum benefit. You need to be thinking about doing the PIK3 mutation analysis upfront also. Every time you have a disease progression, consider doing a biopsy if possible to see if there's a change in the status. Pay close attention to the family history and genetics and learn to collaborate for the patient's benefit. So the next story is titled as, does this hospital have a medical oncologist? I mean, this was the most stunning question that somebody ever asked me. So the story goes like this. This is Mrs. TD, operated outside in 2015, undergoes a surgery for locally advanced breast cancer. She's T2 and 2 and 3, so stage 3. She's all the hormones positive, and especially the HER2 hormone is expression is there. So what is HER2 positive breast cancer? Traditionally, patients who have the overexpression of the HER2 gene or amplification of the HER2 gene used to do traditionally very poor. In 1995, a drug called trastuzumab was approved for metastatic breast cancer. And this man called Slayman Danis played a very huge role in drug into practice. And because he kept bugging people around and his work was very disturbing, he was called Dennis the Menace. But for all the work that he put, it revolutionized the way we treat these patients. So what happens? She followed the standard script before she comes to me from outside. She got standard therapy with trastuzumab for 1 year, radiation, hormonal therapy, and disease progression before she comes to me. So this is a landscape which shows you this, as I said, the white star that you see is the HER2 gene that is expressed. And today you have drugs blocking the HER2. You have drugs blocking the HER2 interaction with other drugs. You have downstream drugs that block the activation of HER2. And then you have TDM1, of which we'll be discussing. So what is trastuzumab? It is a monoclonal antibody. It is a humanized monoclonal antibody. It blocks the activity of the HER2 gene, and it helps to prevent the self-proliferating. And it is a targeted therapy. What is pertuzumab? It's a cousin of trastuzumab. It acts in combination with trastuzumab. What it does, it prevents the HER2 from combining with the other HER genes along with it. And it adds to the toxicity of trastuzumab and gives you a better results. This patient had disease progression outside, and she had already received 1 line of therapy with lapatinib and capecitabine, which was standard of care. Now, the center outside had also done a biopsy again on disease progression to confirm whether it is the same clone, which is very well done. And when she comes to me, she had progressed on capecitabine lapatinib. And I will never forget this patient. 4:45, I'm on the way out. One of the earlier patients that I've seen. I don't know how she came to me. She walked into me as I was walking out of the reception. She said, "Does this hospital have a medical oncologist?" I said, "Yes, madam, I can. And I am the one. Can I help you?" She takes out a paper from her hand and shows, "Can you give me this drug in CMC?" And I looked at the paper and I said, "Oh my, why not?" I felt like carrying her and running her to the OPD. So she wanted me to give this drug. So this is trastuzumab entomestane. It is a TD called TDM1. What this drug is, it is trastuzumab, and it is linked to a chemotherapeutic agent with a linker. So what, in a layman's term, is it is like a laser-guided missile. The trastuzumab will hone into the HER2 positive cells, internalize into the cells, and once it is internalized into the cells, it releases the chemotherapy into the cells only. So it's highly targeted. This drug was approved in relapsed refractory disease by a few trials. I had used this drug as a postgraduate once, but after that, I had not seen. So when this patient came to me, this is the first time I used a high molecule. So I was thrilled. And she had metastasis. The liver was started at that point of time. So we used TDM1. And till date, I would say this is probably one of the best drugs that I've used. She got 20 cycles on a 4th-line therapy. Excellent response. She even had a metabolic CHA. Extremely good quality of life. All these patients that I've discussed hardly got admitted at any point of time. No diarrhea, mucositis. But then after 20 cycles, she disease progressed. We spoke to the family, discussed a lot of options. And then I tried to keep her the trastuzumab backbone and change the chemotherapy. It didn't work. I used an old school technique of giving oral metronomic chemotherapy, that is slow, sustained oral chemotherapy. It really worked on her for a long time. She got another 6 months, disease progressed. Now, the US FDA has approved a few drugs like N-HER2 for patients who progressed even after TDM1, but that's not available in India. And the family was keen on trying it, but then because of the COVID, getting the drug across was difficult, so we couldn't do it. She rapidly progressed after the oral metronomic chemotherapy, and she passed away 2 weeks back. But a huge learning experience of the quality of life, the toxicities, hardly any toxicities in these drugs. Another patient very dear to my heart is this lady. I will never forget this husband. Again, everybody comes in the evening, the time that you want to go home. He literally barges into my OPD and says, he puts a file on the table and says, he refused to take even an OPD card. He said, "Can you treat this here?" I looked at the file, I looked at the profile, and I said, "Yes, I can. Show me the patient." He said, "Patient is in the car. I want to know what is the plan." And he was angry, upset, so I could understand what was happening. Somebody had just told him the diagnosis. He was panicking in his heart. So basically, this is a young lady. This lump is not the history, actually. She's had low back pain for 2 to 3 years, evaluated outside. And The MRI lumbar spine shows multiple altered bone marrow infiltrations, and somebody thought of the possibility of multiple myeloma on this patient, and they did a bone marrow biopsy. Now, this bone marrow biopsy came and it showed it was metastatic and it was hormone receptor positive breast cancer. And then they did a PET scan, and there was a very small primary. Even to this day, I can't palpate that primary, but extensive bone mets. So I remember talking to the husband, and I said, "Sir, listen, there are things that we can do, but I need to see the patient." He walked away. I never thought he'd come back. 2 days back, he came back, said, "Okay, tell us what you can do." And luckily for me, I'm not exaggerating. 10 days before this patient comes to me, I had gone to Chandigarh for a meeting and I had presented the Mona Lisa 7 data as a best of ASCO update. And the Mona Lisa 7 data dealt with patients who are hormone receptor positive, premenopausal women using CDK4 inhibitors showing an overall survival advantage. And on the way back from Chandigarh, I kept thinking, will I ever be able to use such drugs in India? And will I get such a patient? And right in front of me was dying this patient. So I spoke to him. In my heart of hearts, I was panicking because, as usual, I discuss with my colleagues and my seniors what treatment plans. At this point of time, chemotherapy was still considered because she had extensive disease. Bone marrow was infiltrated. A lot of people said, "Listen, this is visceral crisis. All these drugs may take time to act. So start chemotherapy, weekly paclitaxel, and then bring in your hormonal agent after that." But then in my heart of hearts, thought I presented the data, and the data also had patient visceral crisis. I need to really try this. So I spoke to the family. As usual, most of the patients resist chemotherapy. Luckily for me, I didn't want to push it on him. So I said, fine, we will try something new. So the first thing, the challenge that I face in this patient is she's premenopausal. I have to suppress the ovary. Now, what is the best way to do it? At this point of time, suddenly you realize that what you learn and what you practice is so different, so difficult. Should I go for an oophorectomy? Should I use Groselin? If I use Groselin, I have to wait for some time to start the chemotherapy, to start the hormonal therapy. What do I do? Can I use Degrelix? I was so unsure. So I used tamoxifen on her for a week. She started feeling better. I used morphine to control the pain, used zoledronic acid to control the pain. And once she was slightly better, I got gynecology to see her, and they did a laparoscopic oophorectomy, settling the issue. And as soon as that was done, I started on letrozole and ribociclib. Now, what I saw, once we started her in August 2019, she's on 3 monthly zoledronic acid. What I saw is this: complete metabolic response, no FDG activity, tremendous response. As of now, she's doing extremely well. Walks into my OPD. They've done so well that they come only once in 3 months for a visit. Every month they do a WhatsApp call, send me the reports. They say they can't come all the way. I mean, sometimes I feel bad that they've taken the treatment too lightly, but the quality of life, the time that she spends with her children, it's tremendously. I mean, it is something that changed the way I treat cancer, and I really think that this is the way to go forward. I know that at some point of time, I keep telling the family that resistance would happen, but as of now, I hope the honeymoon will last. Now, coming to lung cancer, one cancer that changed the landscape tremendously is lung cancer. Like I said before, 2013, when I worked with Dr. Kunal, everybody got chemotherapy. At the max, somebody would have got EGFR, that's about it. When I started my career in 2013 as a BM resident, chemotherapy played a huge role. By the time I finished, things were changing so much that now I hardly use chemotherapy in these agents. There are a lot of things that you look into when you treat lung cancer, and smoking is not just the only cause. So 2018, a huge thing that happened in the field of medicine is the Nobel Prize went to two gentlemen who did pioneering work in the 1990s, James P. Ellison and Tashio Honjo, for their work on the work behind the principles of immunotherapy, something that has changed the landscape of the life of a medical oncologist. So in a nutshell, what exactly is immunotherapy? As like before, we have played a huge role in understanding the hallmarks of cancer. And one of the hallmarks of cancer is that the tumor cells are able to evade the body's immune system. Now, how do they do that? They have a receptor called a PD-L1 that binds to the PD-1 receptor on the T cell. And by doing so, the T cells don't recognize the tumor cells as abnormal or as non-self. So they let them pass by. So they do not attack these tumor cells. Now, when we understood this, we said, let us then unblock it. And we developed drugs which can block the PD-L1 and also the PD-1, and thereby making the T cells understand that these cells are abnormal and making them attack the cancer cells. So this is in a nutshell what these drugs do, and tremendous responses. I do say that we have used a few. Not all the time you can be successful, but for those patients, this drug works. It works remarkably well. So to start off, this is the first patient that I had, 69-year-old lady. If you read the history to understand, they must be high profile. They were in England, treated with papillary thyroid cancer in England. Their son was an ENT surgeon there, for treatment there. Then they're back to Ludhiana. And then she comes to me with a history of some dyspnea for 2 months duration. Now, outside, she's been evaluated. A PET scan shows pleural deposits, large nodes, biopsy done, no carcinoma lung. And again, a very important thing to understand is as per the changing landscape in cancer, what happens is that when you have non-smokers, adenocarcinoma, you're thinking that most of these patients will have an underlying driver mutation that is causing the cancer. So in Asian patients, this is as high as 30 to 40%. So rightly done, this patient was tested for AL cross EGFR and PD-L1, and PD-L1 was 0%. So at that point of time, she was evaluated outside. So they started on chemotherapy. The family comes to me after the first cycle of chemotherapy. So as I sit across, again, I'm kind of lucky as an oncologist. Whenever I'm jobless, I tend to read something. And I was reading to this article before the patient had come to me. I don't remember how long before. And as I was reading, I realized that a subset of patients in the keynote study did not have a PD-1 positivity, and the drug was still used in them. So I kept wondering, what is the principle? On one hand, we say that PD-L1 is, if the higher the PD-L1, the drug works, that we agree. At this point of time, the NCCN did not approve using immunotherapy in patients who are PD-L1 negative. Now it is standard of care, irrespective of PD-L1 status, to use immunochemo combination upfront for all patients. But at that point of time, it was not standard of care. So I spoke to the family, and even before they told me, I said there is an option of trying immunotherapy, but the data is not heavily in this patient. They said, doctor, we are doctors in the UK. It is standard of care here. So please go ahead. You're the only one who said that this can be tried. So let us try it. So this is a huge learning for me. PD-L1 was negative. We tried. Today we look at combined proportionate scores. We look at tumor mutational burden, MSI, a lot of factors. A lot of factors pushed me, and I said, let us try it. And we tried immunocure combination pembrolizumab and chemotherapy, used 4 cycles. And once the 4 cycles was done, I did a PET scan, showed complete metabolic response. I took off the chemotherapy, put her on pembrolizumab, pemetrexed maintenance. Pemetrexed maintenance I used because she was PD-L1 negative, so I was a bit hesitant. She got around 1 year of maintenance with pemetrexed and pembrolizumab. Then I took off the pemetrexed also. Now she is, I think last week she got a 30-second cycle of pembrolizumab. Extremely good performance. What I saw, PET CRs, performance status 1, no admissions. And what is my plan? The data as of now supports continuing immunotherapy to around 35 cycles. That's 2 years of therapy. After that, you can keep the patient on follow-up or continue immunotherapy. That is something I'll discuss with the family. Immunotherapy is not light. It is something different from chemotherapy. It can cause a lot of symptoms which are unexplained because it is what you're doing is you're unleashing your T cells to go and attack. So a lot of things like immune-mediated toxicities, endocrinopathies can come in these patients. You have to keep them on a close follow-up. But one thing I've learned in a short time is that for those patients who do well, they really do well, they don't develop. For those patients who start developing toxicities in the initial cycles, that sort of patients tend to do bad. I don't have a lot of data, but I'm collecting the data to see how it's. Another patient who changed the way I looked was this man who came from Jalandhar. The family had gone to Delhi for an assessment, like all the patients, they gone to Delhi, and from Delhi, somebody had given them a number, and they kept calling me throughout the time saying, we want to come to you. And every time they were sending me reports of the treatment. So they were walked up in Delhi. He had cough, and he had a hilar lesion, multiple lung lesions. I knew from the PET scan what it was going to be. And when the bronchoscopy was done, I knew it was a hilar lesion. It was going to be a small cell lung cancer. The biopsy showed the same. So this patient, I was kind of prepared. So they never brought the patient to me. So they kept coming to me on the phone. Then 1 or 2 letters will come, testing the water, testing the doctor, his knowledge. So I said, listen, just recently, immunotherapy is approved in this subset. I already have used immunotherapy in another subset. If you want, we can try to use it here also. The data is not all that great like other cancers, but small cell cancers uh, then are very aggressive cancers. They're like leukemias. They have a rapid turnover time. If you give chemotherapy, they respond very well. But the moment you stop the chemotherapy, the disease will come back. The median survival is just a year with therapy also. So I said, see, this is what you have, and this is what I can offer you. They said, this is what has been told in Delhi. We want to take that from you. So I said, fine, this is our plan. We will use atezolizumab with etoposide carboplatin. But I haven't seen the patient. So I said, how is he? They said, he's fine, bit breathless, nothing much. So I said, what about comorbidities? So they said, no, just hypertension for which he's taking some treatment. I said, sure. Yeah, that's about it. And I was also excited. I said, okay, fine, bring the patient. They brought the patient and they brought the medicine also along with the patient. So it's like a trailer. The trailer looks good and the movie starts, you flip. I'm sitting in the OPD. This guy comes in a wheelchair with oxygen. I didn't know what to say. Immediately I told my physician assistant, we will not use full dose chemotherapy. We have to modify the dose of chemotherapy, make it 75% dose now. I shifted them to the ward and I'm panicking. And I called my best friend at that point of time, Chepsi, and I said, what do I do? He said, make sure you treat them well, get them to the best private room, suite room in neurology, put him there, treat them well, and take it forward. So I called Dr. Jairaj sir and said, I need this patient, it's high profile, and I put them in the suite room. Evening 4, the immunotherapy is prepared. I go up to connect it with my staff. As I'm sitting in the bedside, I look into he has a box of medicines. I open the box of medicine and I see a drug and I said, what is this medicine doing over here? I said, what is this drug Davigan doing in your box? The patient just said, I take it every day. It's a blood thinner. I said, I understand that. What is it doing in your box? And his son said, nothing, sir. My dad has a rhythm issue. Once in a while, his heart rate goes up and down. So the cardiologist said, take this and rinse them together. I really didn't know what to say. And this is like, I mean, this is 4:30. The immunotherapy is mixed, prepared. What to say? I just left the room and I said, let God take. And I left the room. Luckily for me, he tolerated everything fine. 1 week after the discharge, he comes back to my OPD. This time he's but not on oxygen. The next cycle of chemotherapy, he comes, he's walking, he's PS1, he's done well. But I didn't want to play a superhero here, so I stopped chemotherapy after 4 cycles of chemoimmunotherapy and put him on pembrolizumab. And once I did that pembrolizumab maintenance, she went on to get around 14 cycles of immunotherapy maintenance. The PET scan showed disease progression after 14 cycles. The family was upset. They said, doctor, we've spent so much of money. So I said, listen, without this therapy, you would have hardly got this time as well. But again, it's kind of difficult. So I said, let's try the second line. They had a first person who's a CMC alumni, who's a medical oncologist. They were discussing with him and said, sir, we need to shift therapy. And I used topotecan here. Huge learning in this patient was the fact that topotecan usually gets you 3 to 6 months as a progression-free survival. Like I said, small cell lung cancers are very aggressive. But what I learned and what the world is learning from these drugs that are immunotherapy and all these drugs is the fact that these drugs have long-term benefits. Ribociclib is known to cause benefits even after stopping it. Same with immunotherapy. We see that after stopping immunotherapy, also these drugs tend to have long-term benefits. So this patient currently has received 19 cycles of topotecan, which I've never had in my life. Extremely good performance status. And he's done so well. I know that this is not going to last a lifetime, but for a patient who had a very bad disease, this is a huge learning experience. Another patient, a huge landmark in which I treat patients, was that male came. He's again referred to me by an old anesthetist who was alumni from CMC. This cough is a retrospective history. I mean, he never complained much of the cough. He had low back pain, fever, weight loss. Evaluated in Amritsar, and as usual, MRI done showed multiple bone lesions. His ESR was high, and one of the CBCs had a rouleau formation. So rightly so, they were working on for multiple myeloma. And they did a whole body MRI for him, like a poor man's pet. Showed a solitary lesion in the brain, parietal lobe, showed a suprachiasmatic lymph node, and they came here. So I did the lymph node biopsy, which showed, as per the IHC, it is pointing towards an adenocarcinoma from a lung. So he's young, a non-smoker, has metastatic lung, and has an oligometastatic brain met. I mean, he's got bone mets, but a solitary brain lesion as well. Now, this is where your judgment as a clinical oncologist. So I knew that somewhere down the line, he has a mutation. And I had made in my mind the possibility of the mutation was going to be this. I knew it. I mean, this is something I judged. I mean, it can go both ways. And this is PET scan upfront, and it showed multiple bone deposits. Hardly any primary. There was some ground glass opacity in the lung. Otherwise, nothing much. MRI showed solitary brain lesion, but he was asymptomatic. So when he was admitted in the ward for the biopsy, I showed radiation oncology. Madam had seen. She said, "Let's wait. Let's see what it is. Don't jump the gun and give radiation. Let us see what it is." And we did a molecular testing for all these patients. Like I said, if you are from adenocarcinoma lung, you do molecular testing for these patients. And in my heart, I was thinking that this is a drug that I want to use, and he turned out to be ALK positive. Again and again, I'm telling you, I go to Chandigarh. I don't have time now, but in those times, I used to be called for meetings, and I used to go, and in all those meetings, everybody will say about the rare drugs that they've used. I used to think, will I ever be able to use such drugs in CMC? And this was my opportunity to use an ALK inhibitor. And understanding the history of these drugs are also important. ALK patients who have ALK positive, 30% of them would have brain metastasis, and that will be asymptomatic, and relapses happen in the brain. So drugs have to be developed to cross the blood-brain barrier. And such a drug that was developed was the drug called alectinib. The data was too good on patients who had no brain metastasis. The progression-free survival was 34.8 months. Now it's even more. Patients with brain metastasis had a progression-free survival of 27.3 months. I offered the patient the treatment. They opted for it. What I saw was he's also on zoledronic acid once in 3 months. Till the time this ALK report came, I had given one cycle of chemotherapy to buy time as well. What I see here is this extremely good response rates, terrific quality of life, too good. I mean, you will not. He also comes to me only once in 3 months now. I mean, he's just taking the pill. Last week only, I gave a talk for a drug called lorlatinib, which is now challenging alectinib in the market, which has a better CNS penetration, which is now saying that the war is on between alectinib and lorlatinib to say which is a better drug at this class of treatment. So that is the way we've managed. And as I come to the end of my talk, as it's an Arabian Nights, I'll have to end it. So I want to work Kaplan my plan for the department. Our focus as a medical oncology department, as I'm in a teaching institution, is a focus on research. We are lucky that we were blessed that we had got a grant from the Department of Biotechnology to set up a clinical trial site, and for which we are heavily funded, and we're collaborating with other sites to do it. And as a part of that fund trials, we have now having clinical trials. We already have 2 clinical trials with us. One is a phase 3 clinical trial on CA prostate, and another clinical trial on a phase 2 study on head and neck cancer. Trials are difficult. A lot of paperwork is done on trials, but I believe that's a way to the future. Also believe that being treated in ADIA, that we have to develop funds for patients. These are difficult patients. Even a standard therapy is expensive. So you need to give good care. You need a backup, which is what I am now heavily banking on getting backup to treat patients. We are going to treat patients on the house if we're getting backup. And also understand that in the era that we are, it's important to collaborate and grow as a team. And that's what I'm really learning and focusing at this point of time. I cannot stop without thanking this man, my mentor and my guru, the Dronacharya in my life, the man who has taught me and made me a medical oncologist, plays a huge role, one email away, one phone call away. I always equate our relationship to Dronacharya and Ekalavian because across the seas is what he trains me. I contribute a lot of my career to this man. This institution, 3 best years of my life, 3 best years was trained here. I'm a huge fan of this place. I was trained by the best, the most ethical teachers. I am here because they trained me. I saw so many patients that I did fear when I saw a patient. I'm thankful for this institution. And this institution gave me a bunch of friends who have hung on to me and criticized, judge, and correct me when I'm wrong. I am blessed with the team of people who work behind the scenes. And trust me, the work is 24 hours because patients keep calling, keep bugging. These guys shoulder me throughout the day. I worked without a house doctor for a long time. They did a tremendous work. I also want to thank the administration. I yesterday also said Dr. William gave me the confidence, the courage. So I always wanted to thank him for that. And I believe God enabled that to happen. Dr. Anil Luther, the MS team has always been supportive. I'm highly encouraged by the principal's office and Dr. Jarad's work. Every time I think if he can achieve it, why shouldn't we try to reach that level? Research is something that Sir said once in the grand rounds that every department by the year of 2021 should have a research project and a grant. At that point of time, I was in the audience and I felt very bad. I said, there's no way with one man, one PA, we are going to get any of these things. And I hate academics. I went back home. I didn't do rounds that day. I told my friends, this is irritable. I'm very sad. But within a year, we had our first grant, and that shook me by surprise. So that's the way we took it forward. I'm supported by a lot of people. The surgical team, the Dr. Parvez and his team, all the surgeons, if I name them, it's difficult. The head and neck team, radiation oncology, for the tremendous support they've always given me. I mean, we spar off in the tumor board on and off, but we hug off at the tumor board. I've been blessed to have a team like that. I can never stop thanking hematology, Dr. Joseph John and the team. I've literally grown on his shoulders. He shouldered me along the journey. We have our spars, but a tremendous team to grow with and to collaborate with. Again, I cannot stop the talk without thanking my parents and my family who bear the brunt of my emotional attacks. I'm here because I've been supported, and I'm here because CMC chose to be with me. Thank you. I open the open discussion.
Thank you, Ashwin, for that excellent presentation. And today I realized that you are a good storyteller also. The way you narrated those, it was very interesting, even for a medical oncologist to, listen to those, names which we can't pronounce. It's open for questions. Anybody there wants to ask Ashwin questions? Yeah. Unmute and you can ask. Parvez, you can ask.
Yeah, Ashwin, thank you for this very, detailed presentation. Just wanted to tell you that when I joined surgery, or maybe even as an MBBS student, we were told that metastatic disease is when you tell the patient, go home and seva karo. That was kind of drilled into us. We never saw metastatic patients being taken care of. And your optimism has actually, was a bit, you could call us pessimistic, but I would say it was enlightening. So way to go. Good. Lot of hard work you put in, lot of sacrifices you made. I'm definitely look at you juggling between two institutes, trying to do your best. So wish you all the best. And we are there always as the entire department and clinical services to support you. Just wanted to ask you one question. How difficult or easy, again, I say as a pessimistic person, how difficult or easy is it to communicate to the family the cost of treatment for a metastatic disease and, then highlighting the survival thereafter?
Yeah, so I'm a kind of a bad oncologist. So I'm kind of blunt to my patients. That's something I'm learning not to do. Most of the patients run away when I say that treatment is expensive. But important thing is that when I sit across the board, I tell them the options. I see, remember one thing, anybody who's coming to you is coming to you after taking opinions. They will go behind your back, take multiple opinions. So always be up to date, give them the standard of care 1, 2, 3, and 4. Document that. So I always say, see, listen, this is what we have. I can't cure you, but there are drugs which are expensive. I can help you to get it at a slightly cheaper cost. If you want to take it, we have patients on it. I can't cure you, but we can try to get you forward if you're willing to move along with it. And I'll be very frank with this. So I do ask the companies to give a patient assistance program, because otherwise it's very expensive. And why would they come to me when there are so many people around? So that is one thing that I do. But I do understand the fact that somehow patients have come back to me again and again. So I must not be a very bad oncologist at the end of the day. So that is something that I've learned. To be frank, tell them the cost, expected thing, and don't tell them that everything will be fine. No, I don't tell them that. So I'll be frank at what I do, and luckily or unluckily, patients have remained back. So it's not easy. It's not easy. It's not at all easy. I mean, it's very difficult, and that makes your life very stressful. The moment the disease progresses or something happens, oh, it is very bad. I mean, you can ask my wife. I go home and I really, really flip. I mean, it's very difficult. I mean, it's very emotional. I mean, it's not easy. It's not easy.
Thank you.
Dr. Pamela.
I had one point. Even when I did my DM training, because Adyar is a high volume center, we would send back patients saying that we will not treat metastatic disease after a certain line because it is expensive. The institution could not afford to take them on board. The first thing that I did when I came and joined and started working is that in my peer group, I said, I apologize to all the patients that we send back from Adyar saying that we will not treat them, because in a tertiary hospital, when I was practicing, I was saying I was desperate for those patients to get in my hand. So that is what is important. Yes, ma'am.
Thank you, Ashwin, for sharing your experience, real life experience with the patient treatment. I just wanted to emphasize something, and I totally agree with you when you said actually cancer is not a single disease. So it comprises of an heterogeneous diseases, meaning there is difference between not only the cancer cells between different patients, but also the cancer cells in one individual patient. Even in a tumor, there is a difference in the cancer cells. We know that. So now I think we have gone everywhere, and then we have taken a full cycle. And with the advances in genomic profiling, like when we say genomic profiling is like you try to get the exact characteristics of the tumor, and then we are doing immuno-oncology closely with precision oncology, like to precisely to hit the tumor because we know what it is. So we are trying to harness our immune system to recognize these characteristics in cancer cells and kill them. Also, each patient is unique. So like you must have seen that, and some patient must be responding very well to these drugs, and some patients you may not get the equal response. So each is unique in the sense they have a different genome, a different proteome, different epigenome, different microbiome, different lifestyle, diet. So all these will have an effect on the oncogenesis, the disease progression, and effective treatment options, developed from drug resistance and all that. So I think it is very nice that there is a lot of advances in targeted, precision oncological treatments. But I think more than everything, the patient selection is very, very important. Actually, patient selection is important. Then most of the time, we will get what we wanted. And also at the same time, communicating the options and what is the survival, and helping the patient from their side is also very important. So thank you for this presentation. So I just wanted to emphasize that.
I totally agree with madam. I have used immunotherapy in patients that 90% feel when I have not got results. So every patient is unique. You cannot, I haven't shown my failures in this presentation. There are a lot of patients whom we have tried and didn't work. Yes, so each patient is different, and that is where we are learning as sequence genes and all those things. So that is an important thing to learn, and we learn as we go ahead, no doubt.
Anybody from the medical side? Dr. Vikas, I can see. Anybody else who are using Ashwin's service? Would you like to ask Ashwin something which you wanted to ask after the lecture? Okay. Can I request Dr. Jairaj and Dr. William to give their final comments?
I'll just make a comment. Dr. Ashwin, thank you. For me, it is a great learning. The precision medicine, the way it is advanced in cancer care. I would say among all the specialties, I think oncology is a field where you have so much of precision medicine, and before you start a treatment, you need to do some gene testing, mutation testing, and find out which patient is going to respond. But slowly in other fields also it's catching up, and in the past, we have thought, okay, somebody has a Mets, okay, that's the end of the story, and we try to counsel them, but the way the advances happen in oncology, we are able to give a good quality of life, whatever time period that they are going to live, they can spend with their family and whatever life's wishes that they wanted to achieve during that period. So thank you very much for this talk.
Yeah. Dr. William, your final comment before we
thanks, Ashwin, for your excellent presentation, particularly your experiences and sharing your experiences in last 3 years of your work in CMC Ludhiana, and the way you have made progress. It is an encouragement for all of us in field of research as well as patient care. One thing you have mentioned is you always discuss with your peers, friends, others before making decisions for the patient. That is very important rather than individually making decisions. And, because you won't get second chance, third chance. It's like that. You are dealing with end stage patients. Other thing you have mentioned is collaboration to move forward. That is must. The way competition we are facing, and you had mentioned in your presentation, patients are well educated before they come to us. So all of us have to know about the disease and treatment options, because it is must these days to make sure patients are visiting a hospital. So I hope in future you will progress further as far as research and patient care is concerned. Good job.
Thank you, Dr. William. Next week, we would have Dr. Deepak Samson Singh, our own graduate and postgraduate from Chinchpada Christian Hospital, presenting the work that they are doing in the Mission Hospital. And until then, have a great weekend and see you next week. Thank you.